Hello, my name is Mike Gannon. I'm the Training Center Coordinator for the Allegheny General Hospital Training Center for the American Heart Association. I'm alone in the studio today for our video presentations, and all instructors will be by themselves individually. When 2 or more instructors were present, proper PPE was utilized. Welcome to Part 1 of your American Heart Association Advanced Cardiac Life Support Certification Training. This video will review the necessary material and teaching stations to prepare you for the in-person written exam and skills testing. We encourage you to take notes throughout the video and bring them with you when you schedule to complete Part 2 of your training. You'll be required to complete the written exam individually. However, we will allow the use of any notes you bring, along with the handouts we'll provide to you when you arrive. Please contact the Training Center with any questions. We're here to help. Thank you, and we look forward to seeing you soon.
Hello, my name is Tom Leslie. I'm a flight nurse for Allegheny General Life Flight. I've been doing this for about 13 years, a little over 13 years. I also have taught many PALS ACLS classes, so you've probably seen me doing one of these classes if this is a renewal for you. Today, we're going to be talking about respiratory arrest and airway control in the adult patients. As far as the agenda for this station, we're going to first talk about oxygenation and ventilation. Then we're going to go ahead and we're going to talk about airway adjuncts from your basic to your more advanced. And then we're going to talk a little bit about end-tidal CO2. I believe it's a very important thing that we're going to be seeing in the future. And right now we're just kind of using it for a couple basic things, which we're going to go over. And then we're going to kind of wrap it up a little bit, and then we're going to talk a little bit about some of the exam questions and stuff like that. Okay, so let's talk first off about oxygenation and ventilation. Okay, two very important parts, of course, with respiratory things. They both work together, but they're both separate, and we can control them separately. And kind of assist each of them separately. So we'll start off talking about oxygenation. The American Heart Association recommends that your pulse ox range remains between 94 and 99%, okay? And again, that is for right now with the American Heart Association. If you have some other kind of departmental protocol where you need to keep them like right around that 90 range or somewhere around there, that's fine. Keep doing what you're doing there. But as far as the American Heart Association, we're talking 94 to 99%. And you notice I've repeated that a couple times. You're probably going to see that again. So I tend to dwell on things like that. So 94%, anything less than 94%, we're going to be adding oxygen. The big thing to take away from this is we don't want to flood these patients with oxygen anymore, okay? So if somebody's like 92, 93%, and we need to get them up to that 94, 95 plus range, we're going to start them off with a little bit of oxygen and keep adding until we get to where we want to be. We don't just want to automatically throw them on a non-rebreather. As far as the 99%, why are we not going 100%? Everybody wants 100%. I want you to give me 100%. I want 100% on all my tests. 99%. So we're finding that a lot of the ischemic issues, your MIs, your strokes, those kind of things, they tend to not do so well if we over-oxygenate. Oxygen toxicity, it has something to do with freeing free radicals, and they tend to not recover as well, or things like that. It kind of changes the anatomy up a little bit. So we want to make sure we're not giving them too much. Of course, if they're on room air or a couple liters of oxygen and they're satting 100%, that's fine. Our concern is if we draw blood gas on a patient that's on a non-rebreather, that's on a ventilator at 100%, we draw blood gas, our pulse ox is saying 100% on a screen, and our blood gas may show a PaO2 of 500 or 400, which is where we don't want to be, okay? If that PaO2 is, 110, 105, we're okay with that, okay? We just don't want that 400 to 500 on our PaO2 level. So that's why we're saying 99% if they're on oxygen, okay? As far as ventilation, so the big thing with ventilation is there's two aspects to it, okay? If you can think on a respiratory therapy term of minute ventilation, that's what we're talking about. We need to make sure that they're getting adequate volume, and that they have an adequate rate. You know, you may have a patient that's a postictal seizure or a drug overdose or something like that. They may have very good chest excursion, but only breathing 4 times a minute. So they're lacking that rate. So their minute ventilation is going to be too low. We need to assist them, okay? And again, if we're using a bag valve mask on a patient, we want to give them just enough to expand the lungs. We don't want to empty that whole bag into their lungs and possibly cause some lung damage, okay? As far as a rate, okay, so if I am assisting ventilation on a patient that is, again, a postictal seizure, drug overdose kind of thing, they're not having enough rate to keep up with what they need to do, I'm going to squeeze this bag 1 breath every 5 to 6 seconds, okay? And that's 1 breath every 5 to 6 seconds, and enough just to get chest rise and let it go, okay? I would kind of want to get them in that sniffing position. So I want the head back a little bit, maybe a towel roll under there, just to get them in that sniffing position to open that airway. The next one I want to talk about, of course, is the arrest patient. So if I am using a bag valve mask with the mask, I'm going to assist respirations with compressions, okay? I'm going to give 2 breaths every 30 compressions. So the person doing the compressing is going to give 30 compressions. I'm going to give my 2 breaths, and then they're going to start compressions again, okay? The other one I want to talk about is a patient with an advanced airway in an arrest situation. So an advanced airway, you know, we're talking about a trach or any of these devices, okay? So your endotracheal tube or a subglottic airway and a trach, those are all advanced airways. If they have an advanced airway in and the patient is in arrest, we are going to give 1 breath every 6 seconds. And we're not concerned about compressions because they're going to do continuous compressions. While I'm up here managing the airway, I'm just going to give 1 breath every 6 seconds. Kind of went over those a couple times, so you're going to probably see some of that stuff again later. All right. So that is the ventilation part of it. Again, the big things to take away: enough chest rise and what our rates are. Okay. Okay. The next thing we're going to talk about is the adjuncts. Okay. So some of your basic adjuncts. I don't have a suction catheter here, but I feel a suction yonker, suction catheter, something like that is very incremental in managing an airway. A lot of these patients have, you know, blood, vomit, sputum, whatever. We need to clear that airway. So make sure, and I've been in pinches before where we had everything together, everything was connected, everything looked nice and pretty, but the equipment wasn't working. So just make sure your equipment's working, make sure everything's together, good to go, okay? The next thing I want to show you, you won't need to know this on the test either, but these are called McGill forceps, okay? So if you have never seen McGill forceps, this is what they are. They're very good for plucking foreign bodies out. The reason I show these is they're probably going to be on your crash cart in the airway part. Somebody may ask for them. And if somebody asks for them, if they ask for the McGills and you just stand there and go, what are you talking about? Then, you know, you're going to kind of feel bad about it. But this is what they're talking about, the McGills. First basic airway adjunct is your nasopharyngeal airway, your NP airways. Okay, so most of them are different looking than this. This actually has a little cuff thing that will go up and down to adjust your depth, but most of them are a fixed airway. What you need to do as far as measurement for this, we're going to go from the nary to the tragus of the ear. So you're going to kind of just bring this up here and you're going to go there to there. Okay, so when I place it, I'm going to lubricate it, find my best opening. I'm going to start advancing it, twisting back and forth as I'm advancing with a little bit of pressure, not a lot of pressure, until we get that fully in, okay? Once it's fully in, we can add oxygen, we can bag valve mask over top of it, whatever needs to be done. Again, 94 to 99%, appropriate rate, appropriate volume, you're doing your job, okay? The other big thing to take away from this is contraindication, okay? So the contraindication for an NP airway is facial fractures, okay? Facial trauma. We want to make sure that there's no fracture behind that we can't see and that we're inserting it and possibly poking into the brain. We don't want to do that, okay? So measurement, contraindications are a big thing to take away from this. All right, OP airway, oropharyngeal airway. Definitely, a harder plastic. We used to teach to put it in this way and then twist motion down. We don't want to do that anymore, okay? Textbook way of doing it is that we're just actually going to get the tongue with a tongue depressor or something similar to a tongue depressor, and we're just going to slide that in like that, okay? You can use a yonker. There's been times where I've used a gloved hand with my thumb. Just be careful with that. We don't want you being bit. Once it's in, again, the big thing is to oxygenate, ventilate as needed. Measurement for this, you're going to go corner of the mouth to the angle of the mandible. Okay, so we're actually just going to kind of put it up there, corner of the mouth, angle of the mandible. All right, and I showed you how to place it. Contraindication for this is a gag reflex. So if a patient, they have to be obtunded enough that they do not have a gag reflex. Okay, so if they do have a gag reflex, of course they're going to regurgitate and probably aspirate. So we got to be very careful with that. Okay, so the more advanced airways that we're going to talk about, we are going to talk about endotracheal tubes, subglottic airways. Okay, another advanced airway, of course, is a tracheostomy. Okay, as far as endotracheal tubes, a couple things. If we're preparing for intubation or whatever, we need to know what size we want to use. So as far as size, I usually use, for adult females, I'll use 7.0 to 7.5. For adult males, usually 7.5 to 8.0. Okay, and I usually go lower end of normal just to make sure I get the airway in place, and then we can switch them out as needed later on. A couple of big things to check: you want to make sure that your cuff's going to hold air. So you want to put a little bit of air in it, make sure it's going to hold air, and then take all that air out. Prepare that for whoever's going to be intubating. The other thing, you want to ask somebody who's intubating what blade they're going to use. This is a Miller. Looks like an L, so that's how I remember this early in my career. Miller has 2 L's in it. This is a Macintosh, which kind of looks like a C for Mac. This is probably the more popular blade, but whatever the person doing the intubating is comfortable with, that's what they're going to want to use. So just find out what they want to use. Make sure everything's working. The light's nice and bright. Everything's nice and tight. Okay. So these are subglottic airways. I have 2 of the King LTDs. What you'll do is you'll see these primarily pre-hospital, but what happens is both of these types will be inserted blindly and kind of into the esophagus, which is where you want them to start heading. We'll go over this one here in a second. But the Kings, we're going to put it into the esophagus. These balloons blow up. This blows up in the esophagus. This is blowing up in the upper oropharynx kind of thing. And then right here is where we're going to be ventilating. And that should be facing towards the cords. Okay. Different sizes. That's why I have a couple of them here to show you. And it depends on the height of the patient. And they'll tell you actually on the packaging what size you should be using. This is your LMA, laryngomask airway. You'll see this mostly inter-hospital, especially in the ORs. Okay, this is where anesthesia uses a ton of these for short-term surgeries. The big reason I'm showing them to you is that you will see them probably on your crash cart or your emergency airway cart as kind of a rescue airway, along with this device. This is called a bougie or a gum bougie. As you can see, it is smaller in diameter than an endotracheal tube. So as far as placing this, it's a lot easier to place this. It actually has that coude tip also, which is kind of bent. And that will get up to your more anterior airway. What we'll do is we'll put this in and then slide the tube over. And the same thing, if I need to switch tubes, I can put this through the tube that's existing, pull it out, put a new one on. Okay, so again, just like the McGill's, show it to you, it's called a bougie or gum bougie. So if you've not seen it or heard it, what it is, at least it'll be in that little closed box in the back of your mind that you can grab it and understand what they're talking about. Okay. So those are the more advanced airways that we just went over. We're going to assume, we're just going to pretend that this patient is now intubated. Okay, so if I am intubating a patient, we need to confirm that it is in the trachea and not in the esophagus, okay? Many ways we can do that. Most people will start auscultating, okay? So what they want to do is they want to listen over the belly first, okay? So if you hear gurgling over the belly, you know it's in the esophagus because it's going right to the belly. So if you hear gurgling over the belly, immediately you know the tube is not in the right spot, okay? And then if you don't hear it, you know, you're going to listen to your breath sounds, okay? The gold standard is end tidal detection of some sorts. This is the most basic that they want to see. This is your easy cap or your end tidal CO2 detector. This one actually comes out of the box. It is blue in color, and in the presence of carbon dioxide, it'll turn yellow. So what we're going to do is we'll put that on and we'll start bagging, and we're going to start watching to see this turn yellow. If it doesn't turn yellow in about 4 or 5 breaths, then we're going to be concerned that it's not in the right spot and consider pulling this out and going forth with reintubating or managing the airway some way. So this device, we're going to talk extensively about this here in a minute. A little more extensively, I should say. So this is continuous waveform capnography, or as you're going to see it on the test, it's going to be listed as PETCO, PETCO2, okay? So this is actually much larger length. This is just kind of cut down for display purposes, but this will plug into your monitor, and then once we intubate the patient, we're going to put this on there, and with each exhalation, it's going to go ahead and give us a waveform and some numbers, which we're going to talk about here in a second. Okay, 2 quick things we're going to talk about with end tidal CO2 and capnography. So it will tell us 2 things for sure, which are the most basic things that we're concerned about right now with this course. It's going to tell us tube placement. It's also going to tell us perfusion, how the patient is perfusing, okay? And there's a couple questions on the test about end tidal CO2. And again, PETCO, PETCO2 is how it's going to be listed on some of the questions. All right, so once I have a patient that I feel is intubated, I'm going to put the continuous waveform capnography on. It's going to be connected to my monitor. And what I want to see initially is a waveform, okay? And I'm going to show you this waveform here on the screen. And as you can see, it'll deflect up. So any kind of deflection upward is the beginning expiration. Then you're going to have your expiratory phase, and then you're going to see a deflection. The deflection is actually the beginning of inspiration again. Okay, so you want to see one of those waveforms for each exhalation. Okay, so once you see that waveform, no matter what the numbers are, we're not going to talk about numbers yet, but anytime you see that waveform, whether it's large or small, you know that it's detecting CO2 with each exhaled breath. You know that you're in the right spot. So that's why this is very good to tell us about placement. In the pre-hospital setting, very nice. We're moving patients from A to B to C to D to E all the way down, okay? So every time we move, we take a risk of pulling our tube out. This will tell us second to second if that tube gets dislodged or not, okay? So as long as we have that waveform with each exhaled breath, we know the tube's in. So it's very good for placement, okay? Again, this should all be secured with some kind of commercial device, so it should not move once we have it in place. But with this device, we leave it in place to continuously check to see if it's going, okay? The other thing is perfusion, okay? So now we're going to start talking a little bit about numbers. In order to exchange gas, in order to take in oxygen and give us back CO2, we have to be perfusing, okay? If we're not perfusing, we're dead, correct? So this is a very good indicator if we're doing good CPR, okay? So even more so than checking pulses during CPR. I would rather have this in place. So as we're doing compressions, we should see that waveform and we should see our numbers in a decent area, okay? So we're gonna talk about numbers real quick. So the American Heart Association gives us the number 10. So anything less than 10, they're saying very poor perfusion, okay? So if I see that I have an appropriate waveform, meaning that the tube is in place, that is not an airway issue, but I see the number 8, I know that I'm not perfusing, okay? So what should I be doing? Should be jumping on the chest and doing compressions. If I'm already doing compressions and my number's 8, I need to be doing better compressions, okay? So as I start doing compressions, and that number 8 should start going up, okay? So we'll say I'm doing good compressions. My number is now up to 20, okay? So once I get that number to 20 or whatever, and I'm doing good compressions, and all of a sudden I see this spike go from 20 to 50 on my numbers, that's when we know we have return of spontaneous circulation, or ROSC, okay? So the American Heart Association, who says you should never stop compressions, they actually say stop compressions and check a pulse if you see a big spike in your numbers on your end tidal CO2, okay? Normal end tidal CO2, textbook 35 to 45, okay? And again, depending on disease process, what's going on, you may never get 35 to 45. You just need to know that's the direction you want to go. If it's too high, we're going to try to come down. If it's too low, we're going to try to come up, okay? So remember the number 10. Remember that my big concern with airway is the waveform. If I see that I have a waveform, I know it's not an airway issue, okay? If I see I have really bad numbers, I know it's a perfusion issue. So again, you're going to see a lot more to come with this device in the future. I think you're going to see one on every intubated patient in the ICUs here coming soon. Very good device, very nice to have on monitoring your patient. What is a good indicator of pulselessness in a patient? Okay, a couple of your answers are going to be cyanosis and agnal gasp. Okay, I like to tell people that you can be cyanotic and still have a pulse, correct? I could jump in my pool in the middle of January and get out, and I will probably be cyanotic, and hopefully I'll still have a heart rate. Although when I hit the water, I probably will lose a heart rate. But they're saying agnal gasp. And I think the reason that they have this in there for that question is that they're finding people weren't recognizing that somebody was pulseless. So they would come up to an unresponsive patient and they would see that they were having agnal gasp, which are not effective respirations. They'll see they're having these agnal gasp and they think that they're breathing effectively, and they're not, okay? So they're not starting CPR right away because they feel that they still have a respiratory drive, so that they don't need to start CPR because they still have pulses with a respiratory drive, but they don't. The other thing that I feel that they might be finding is that as we're doing compressions and somebody has an agnal gasp, our first tendency is to go, oh, he just took a breath, and pull our hands off and stop compressions. They don't want that. They want you to continue compressions. Again, not an effective respiratory pattern, no cardiac output. They need to continue doing compressions, okay? So I think that's the reason that they have that question in there, and it's a very tricky and difficult question to maneuver. So I like to throw it out there. A couple other things to remember. Cardiac output will decrease with excessive ventilation. So if I am bag valving a patient and I'm going at a fast rate, or I'm giving them a big bunch of volume, remember all of that going into there is increasing interthoracic pressure, and your cardiac output is going to go down, okay? So just remember that. Some other things to take away from this, again, PETGO is end tidal CO2, okay? So just remember that. You'll see that again later. Remember the continuous waveform capnography. If you have a waveform, it is not an airway issue. If you have poor numbers, less than 10, it's a perfusion issue, and that you need to start compressions or do better compressions, okay? And again, if you see that big spike in your end tidal CO2, you probably have pulses back, so check pulses at that point, okay? Remember your bag valve rates that you're going to be doing. If you have an advanced airway in an arrest situation, we're just going to be squeezing that one breath every 6 seconds, okay? And again, just enough to give chest rise. If I'm rescue breathing, it's one breath every 5 to 6 seconds. And just remember the number 6, and you'll get a couple other questions right. 94 to 99% on our pulse ox, remember that. Remember that in order to check placement of a tube, you're best off with end tidal CO2 detection. Remember, chest x-ray doesn't tell us placement of the tube. It'll tell us depth of the tube. It'll tell us it's in the right depth. It's not right main stem. It's not too shallow, not too deep. Okay, but it cannot tell us that it is in the, especially a straight on chest x-ray. It's not going to tell us that it's in the right hole. Okay. If you have any questions, please give us a call or, whatever. And I hope you do well on this test and do well clinically. Thank you.
Hi, my name is Karen Glass. I'm a flight nurse at Allegheny General Hospital, and I'm also a paramedic. We're going to talk about EKG interpretation for ACLS. Whenever you look at a monitor, two things you want to ask yourself. Number one, do you have a pulse with whatever is on that monitor screen? If it doesn't have a pulse, it's pulseless electrical activity. We're going to begin CPR. We're going to give them epinephrine 1 milligram every 3 to 5 minutes and look for the cause of the arrest. The other thing to think about, do you really have normal sinus rhythm on that monitor? People walk around for years with arrhythmias until someone actually puts them on a monitor, and then they find out that there is an abnormal rhythm there that they will need to treat, like Wolff-Parkinson-White. And then if you do see that, you're going to call someone immediately to take a look at it to make sure that they are treated appropriately. If they do have a pulse, stable versus unstable dictates your treatment. We're looking for mental status changes on everyone. We're looking for any sign of failure on everyone. Treatment is always predicated on what that blood pressure is. 90 is your minimal acceptable blood pressure on everybody. 90 and above, we consider them stable. If they're less than 90, they're in shock. We're looking at fluid, pressors, blood, maybe cardioversion, depending on the arrhythmia for treatment. Then what caused our problem and how are we going to fix them? Causes, we look at all the H's and T's, and specifically for the OB patients, in addition to the H's and T's, we look at bow chops. Things that you look for to analyze your rhythm. Is there a P wave for every QRS? A QRS for every P wave? Are the P waves upright or inverted? Is the R to R interval regular or is it irregular? Normal PR interval is 0.12 to 0.20. Less than 0.12 seconds, it's either junctional or it's Wolff-Parkinson-White, depending on the way the P wave is flipped. If it's greater than 0.20 seconds consistently, it's a first-degree AV block. Normal QRS width in the adult is up to 0.12 seconds. 0.12 and greater could be a bundle branch block, an elevated potassium level. They may be on a drug like procainamide that acts by widening out the QRS. Some cardiac surgeries leave you with a wider than normal QRS complex. QT intervals are rate related. We need to look at that QT interval for several reasons. If your magnesium or calcium are low, the QT interval will naturally lengthen. And if they start on any one of the over 2,000 medications that act by lengthening the QT interval, you can set off arrhythmias in these individuals. And some of those drugs include Cipro, Levaquin, erythromycin, Avelox, Zofran, amiodarone, dopamine, dobutamine, Levophed, terbutaline, albuterol, most of your psych meds, Benadryl, cocaine, methadone, and Haldol for the more creative people we deal with. Remdesivir, which is currently being utilized for COVID patients, will also lengthen the QT interval. The other reason why we look at QT intervals, you can be born congenitally have a long QT interval. And there's 3 groups. Each group has their own trigger that sets the arrhythmia off for them. One group, stress will set off the arrhythmia. Another group, exercise will induce the arrhythmia. The third group has a noise trigger, and that will induce the arrhythmia. We're going to look at the ST segment. Is it normal, elevated, or depressed? Youngest person I've ever known to die of an MI was my 17-year-old next-door neighbor. He was a very brittle juvenile diabetic. Patients who get cardiac disease young, we lose them young many times because they don't have a chance to build up collateral circulation like the older folks do. If they have factor V leading, they're hypercoagulopathic, and they can flip off a clot at any age, any time. We had a 16-year-old that we flew who had a stroke, and they treated her with TPA, and it turned out that she did have factor V leading. Patients that are very prone to have factor V leading include patients who are preeclamptic or eclamptic. We still don't know the correlation between the syndromes. If they get into cocaine at any age, they can have a cocaine-induced MI because of the spasms of the blood vessels that they have. We're going to look at the T wave. Is there any change? Sometimes the first sign of cardiac disease, the T waves will invert, and then the STs go up in those leads when they have the MI. If it's a peak T wave, they have a high potassium level potentially. We need to check their potassium level. If they have a U wave, we check them for a low potassium level. And then do they have any ectopics? If they're having premature atrial contractions on the monitor. If you look at the P wave, it's different with the PAC, and it comes earlier in the cycle because it's coming from a cell other than the SA node. These folks have the potential to flip into SVT, atrial fibrillation, so we need to find out why they have that atrial irritability and calm down that site before they go into a worsening arrhythmia. Are they having junctional beats coming from the AV node? It'll be early in the cycle. You may have an inverted P wave before it. It may not have a P wave in front at all. It'll be lost in the QRS. It may have a P wave after. These folks may have a lower heart rate, and they may need evaluated for an atrial pacemaker. If they are having unifocal PVCs on the monitor, they will all look alike, and they are all coming from the same site. These folks have the potential to go into monomorphic VTAC. Mono meaning one cell, one site that's firing, and all the rhythm, it all looks alike. If you have multifocal PVCs on the monitor, they will look differently because they are coming from different sites. These patients have the potential to go into polymorphic VTAC or torsades. And if you see this on the monitor, the cause of this rhythm is a low magnesium level. And it's a twisting on the point. Up, it's down, it's up, it's down, it's up, it's down. Your intrinsic rate for your SA node would be 60 to 100. If that site fails, your AV node hopefully will begin to fire next. And that's a junctional rhythm. And that rate intrinsically will be 40 to 60. And for the ventricles, the rate's 20 to 40. Generally, this isn't enough to sustain life. We're going to check those folks for a pulse, and if they don't have a pulse, we're going to begin CPR. So, to interpret the rhythm that is going to be on the monitor, this is normal sinus rhythm. Everything is completely within normal limits. And if I take normal sinus rhythm and have the SA node fire at less than its intrinsic rate of 60 to 100, so the rate's going to be less than 60, this is known as sinus bradycardia. Symptomatic sinus bradycardia you will usually see with rates less than 50. Emergently, we're going to use atropine with them, or we're going to start pacing them immediately. If they're relatively stable with this rhythm and we have time to mix an IV drip, we can put them on a dopamine drip at 5 to 20 mics per kilo per minute, or an epi drip at 0.1 to 0.5 mics per kilo per minute. And this will vasoconstrict them and increase their heart rate and correct their pressure in their heart rate. The other time to think about a dopamine or an epinephrine drip on these patients is if you put external pacer pads on and the transcutaneous pacer fails to capture. This is going to be your only option until you get somebody to the bedside that's able to float a transvenous pacer. There's also a relative bradycardia that you can have with folks. I had a gentleman who was in septic shock not long ago. His pressure was 60 over 30, and this was his rate on the monitor. He was on metoprolol. If they're on a beta blocker, they can never physically increase their rate to clinically match whatever clinical condition is going on. So we know that heart rate is less than what it should be. They call it a relative bradycardia. If I speed that SA node up to a rate between 100 to 150, you have sinus tachycardia. And your treatment for sinus tachycardia is go through your H's and T's and find your underlying cause and treat it. Other things to think about. Could it be an atrial flutter at a 2 to 1 rate? The rate is going to be 150. If you have a 3 to 1 flutter, your rate's going to be 100. If it's 4 to 1 flutter, your rate is 75. But the one that gets most frequently is the one that is around 100, because if the size on the monitor is too small, it will look like normal sinus rhythms. So make sure the size on that monitor is turned up so you can really interpret those rhythms correctly. The other thing to consider when you look at sinus tachycardia is take a look at the P wave. See if it changed its way it's looked. See if it changed the way it looks. If it's changed its morphology and the way it looks, then you are probably dealing with an atrial tachycardia. But between 100 to 150, you are still treating that underlying cause. If you have a narrow complex tachycardia greater than 150 in the adult, this rhythm is known as supraventricular tachycardia. With supraventricular tachycardia, these folks are candidates for vagal maneuvers, adenosine, and cardioversion. Other things to think about. If you have an SA node that's firing at a rate between 100 to 150, you have sinus tachycardia. Your treatment for sinus tachycardia would be to look at your H's and T's, and for your OB patients, again, BOCHOPs, to see what the underlying cause is and treat it. Other things to think about, look at the P wave, see if it changed its morphology. If it's changed the way it looks, you might be dealing with an atrial tachycardia. But between 100 to 150, you're still treating that underlying cause. And the other thing to consider, could they have an atrial flutter? If you have a 2-to-1 flutter, your rate will be 150. If you have a 3-to-1 flutter, your rate will be 100. If you have a 4-to-1 flutter, your rate will be 75. As long as they're not a combination of atrial fib and atrial flutter and your rate's more irregular, the rates for atrial flutter are very, very predictable. If you have a patient in atrial flutter and their rate's 100, many times this gets misinterpreted as normal sinus rhythm because the size on the monitor is very small. Make sure the size on your monitor is turned up so that you can actually interpret these rhythms correctly. If you have a narrow complex tachycardia greater than 150 in the adult, this is supraventricular tachycardia. These patients become candidates for vagal maneuvers, adenosine, and cardioversion. Depending on how stable they are, it's going to dictate which treatment you utilize. Other things to think about with these patients is what that underlying cause is. I had a trauma patient whose rate was 160. He wasn't an SVT, but he was hemorrhaging. For that individual, he will not receive adenosine, to try and stabilize them. We're going to look at those H's and T's again and see how best to stabilize these individuals. So if you have a patient with a stable supraventricular tachycardia, things that we're going to try to break that tachycardia would be all the vagal maneuvers. If vagal maneuvers don't work, as long as they have no history of Wolff-Parkinson-White, we're going to give them adenosine, 6 milligrams, 12 milligrams. And then they'll consider calcium channel blockers or beta blockers to regulate the atrial arrhythmias. This rhythm many times gets misinterpreted as atrial fibrillation because it's fast and it's irregular. Again, turn up the size on your monitor and take a look at that rhythm. If you look, these patients have 3 or more repeating P waves that look alike. You've heard of wandering atrial pacer? Wandering atrial pacer has 3 different P waves with 3 different ectopic sites firing. If the rate's over 100, 3 different P waves with 3 different ectopic sites firing. This is a multifocal atrial tachycardia. People very prone to this are hypoxic or hypokalemic. We're going to treat the underlying cause, medically rate control them. They don't recommend cardioversion for this rhythm because these are very strong ectopic sites and they won't break with cardioversion. 2 rhythms you see a lot of around Pennsylvania because we have the oldest population in Allegheny County during the summer months are atrial flutter. Rate parameters for atrial flutter are 60 to 100. And for atrial fibrillation, they are 60 to 110. They did a race study and they found that because their ventricles don't fill completely, that just gives them a little more of a kick whenever they do let their rate go up to 110. But again, we're looking for that underlying cause to see if we should treat it. If you have a heart rate with atrial fib or atrial flutter less than 60, and they have a bradycardic response, We have to look at them and figure out why their heart rates are so slow. Conversely, if they have a rapid ventricular response, greater than 100, we have to look at those H's and T's and see how best we're going to treat them. Junctional rhythms are going to look one of three ways on the monitor: an inverted P with a PR interval less than 0.12 seconds. The P wave can be within the QRS complex, or the P wave can come after the QRS complex. Junctional rhythms are a rate 40 to 60. That's the intrinsic rate for your junctional node. 60 to 100, it's going to be an accelerated junctional rhythm. And if the rate is over 100, it's a junctional tachycardia. One rhythm you do need to rule out if you have a short PR interval is Wolff-Parkinson-White. With Wolff-Parkinson-White, you'll have an upright P, a very short PR interval, and you'll have a delta wave. With junctional rhythms, you have an inverted P. So let's take a look at blocks. If you have a PR interval, and your PR interval reflects what's happening with your AV node, so there's a conduction delay through the AV node. If your PR interval is greater than 0.20 seconds, that's a first-degree AV block. People on a beta blocker, like low pressor, you would expect to see this. If they have too much of a beta blocker in their system, potentially this rhythm may occur. You have a PR interval that starts out normal, then it becomes gradually longer, and finally you drop one beat. Then the next beat is normal again. This is Winky block. This is a second-degree type 1. If you have more P's than QRS's, you either have a second-degree type 2 or a third-degree AV block. If you have more P's than QRS's, but your PR is exactly the same, but you're dropping a lot of QRS's, this is a second-degree type 2. Stable, will watch them. Unstable, we're going to start pacing them. And if the conduction quits completely, this is the divorce. Everybody lives in their own house, doing their own thing. There's no rhyme or reason between the P wave and the QRS. The PR interval is changing continuously. Third-degree block. Stable, you watch. Unstable, you pace. This is ventricular standstill. You have a series of P waves, but no QRS response, or you may intermittently have patients with a QRS response. If they're stable, we'll watch them with pacer pads on. If they're unstable, we begin to pace these patients. Let's move down to the ventricle. Idioventricular rhythms, we're going to check these patients for a pulse. If there's no pulse, we're going to start CPR. They're going to get epinephrine, 1 milligram, every 3 to 5 minutes. Look for the cause of the arrest. Accelerated idioventricular rhythms are a rate between 40 and 100. Treat the underlying cause if they have pulses. Once that rate gets over 100, it's ventricular tachycardia. And this is monomorphic VTach. So we'll check them for a pulse. If they're stable with this, then we'll try vagal maneuvers to break it. If vagal maneuvers are unsuccessful, we can give them lidocaine, 1 milligram per kilo, and a 2 to 4 milligram a minute drip, or amiodarone, 150 milligram bolus, a 1 milligram a minute drip for 6 hours, and a half a milligram a minute drip for 18 hours, and then they'll switch them to a PO medication. Amiodarone is 40% iodine. If they have an iodine allergy, you may see a reaction with that. Never put amiodarone in the same line with heparin or give bicarb through it. It will form a precipitate, and watch the potassium level. If they have an elevated potassium level and they receive amiodarone, the next rhythm you may see on the monitor is this. The half-life for amiodarone is 40 days. Be cautious with amiodarone with patients with high potassium levels. If you have a pulse with this and the patient's hypotensive, let's say their blood pressure is 70/30, these patients are going to be cardioverted. If you have pulseless VTach or ventricular fibrillation on a monitor, we're going to begin CPR. They're going to be defibrillated. We're going to do 2 minutes of CPR. They're going to get defibrillated again. At that point, we give epinephrine, 1 milligram every 3 to 5 minutes. We want to make sure the rhythm is refractory, that defibrillation isn't going to work. So everyone gets defibrillated twice before they give that epinephrine. Studies have shown that people who get epinephrine early in an arrest actually don't do as well. So we're going to do 2 minutes of CPR after we give that epinephrine to make sure it's well circulated. Defibrillate that patient again. If they remain in pulseless VTAC or ventricular fibrillation, we're going to give them either lidocaine 1 milligram per kilo or amiodarone 300 milligrams. If you have torsades on a monitor, the antiarrhythmic, if they have a pulse, is going to be magnesium, 1 to 2 grams over 10 minutes if they have pulses. If they're in cardiac arrest, we push 1 to 2 grams of magnesium. Asystole, we're going to check the leads, check them in 2 leads, turn up the size of the EKG. We want to confirm that they really are asystolic and not in a fine ventricular fibrillation. We're going to begin CPR. We're going to give them epinephrine, 1 milligram every 3 to 5 minutes. If you have a return of spontaneous circulation, we want to find out exactly what caused the cardiac arrest. If it is a cardiac issue, we want to get that individual to the cath lab within 90 minutes. That's our gold standard. If they are unconscious after the cardiac arrest, we're going to intubate them for airway control, sedate them. If they're still shivering, as we cool them, we may elect to paralyze them. We don't want them shivering. It will increase oxygen demand. And they are cooled to a temperature range between 32 and 36 degrees for at least 24 hours.
Hi, and welcome to the electrical therapy portion of the Advanced Cardiac Life Support Program. My name is Fred Gerstacker. I'm a paramedic with the Allegheny Health Network, and I am AHA Training Center faculty. Today we're going to be talking about electricity. When I say the word shock to you, most of you will think of the common phraseology of using defibrillation. But shock can mean a lot of things. Shock can mean defibrillation. It can mean electricity. It can mean inadequate tissue volume. So what I want you to do is try and make yourself forget the word shock. If you want to deliver electricity, what I want you to do is tell me what kind of electricity that you want to use. The 3 types of electricity that we use in the Advanced Cardiac Life Support Program is transcutaneous pacing, synchronized cardioversion, and defibrillation. So when you say shock the patient, you could potentially be meaning synchronized cardioversion, but of course, you accidentally defibrillate. And you definitely don't want to start your report off with, "I killed so-and-so." So whenever you talk about shocking a patient, what I want you to do is tell me what kind of electricity you want. If you want to transcutaneously pace, tell me to pace. If you want to synchronize cardiovert, tell me to synchronize cardiovert. Of course, if you want to defibrillate, tell me to defibrillate. So who do we pace? To quite simply broad brush stroke your patient population, we transcutaneously pace symptomatic Brady's. Now, symptomatic Brady's can include a sinus bradycardia, any heart rate that's a sinus rhythm that's too slow, typically under the number of 40 to 60, and they're symptomatic. It can also include second degree type 2, second degree type 1, which is very rare but can happen, and third degree or complete heart blocks. We're going to talk about that later so as not to confuse you. There is a difference in treatment in the treatment regimen of those patients. Synchronized cardioversion, again, broad brush stroking it. We synchronize cardiovert symptomatic tachycardic patients. Symptomatic tachycardic patients are any patient with a heart rate greater than 150 to 160. Now, when we talk about tachycardic patients, what I want you to remember is that it's not all patients with a heart rate greater than 150 or 160. If someone who typically has a heart rate of 50 to 60 walk into your facility and they have a heart rate of 130 or 128 and they're symptomatic, we need to start considering electricity on those patients. Most of the time we're going to treat them with other means, but I want you to realize and put into the back of your head, that synchronized cardioversion might be one of those choices. And the last patients we treat as defibrillation. Defibrillation most of the time is because of a non-perfusing, what we call dead rhythm. We typically call those folks the dead folks. Now remember, there are two rhythms that we do not defibrillate. Those rhythms are PEA, pulseless electrical activity, and asystole. Let's start off slow. Transcutaneous pacing. Transcutaneous pacing is outside or exterior pacing. We're delivering electricity across the chest wall exteriorly to get a reaction from the cardiac muscle. So, who do we pace? Again, sinus bradycardic patients. These patients are usually paced when they're not responsive to atropine. You're going to learn about giving atropine to these patients first. Less invasive to most invasive. We're going to talk about giving those patients atropine and making sure that the atropine is working, and if it's not, then we're going to decide maybe to pace them. Second degree, type 2, and third degree patients. Of course, we don't want to give these patients atropine. Atropine works on the atrium. I mean, that's how it's got its name, right? So you don't want to give those folks atropine, because what you actually have is a functioning atrial rate. That functioning atrial rate is just fast enough. The problem is that separation between the atrium and the ventricles, and that's where our problem lies. So we want to make sure that we don't speed up the atrial rate, because what we'll do is cause those patients to fail faster, and that's bad. So what we want to do is make sure that we try not to give atropine to those patients, absolutely not give them atropine, and we want to pace those patients right away. Now, I can't teach you how to pace. I know I'm sitting here lecturing in front of you, and you're wondering why I can't teach you how to pace. Well, the reason is a lot broader than me just teaching you how to pace. I can tell you what to look for when you do pace, but what I need you to do is make sure that you know your policies and procedures. Everyone in every area of the hospital is different. Some folks pace at a rate of 70 and 70 milliamps. Some folks will start off at 60 and 40. I'm going to throw a lot of numbers out at you. Most of the numbers I'm going to involve, of course, being a paramedic, is probably the pre-hospital numbers. Our Department of Health actually regulates how we pace a patient, and those numbers are at 80 beats a minute and at 80 milliamps. So a lot of times you're going to hear me say 80 and 80. A lot of hospitals have a 70 and 70 policy, which is 70 beats a minute and 70 milliamps. Again, you need to know your policies and procedures of the utmost. That's the utmost important, is knowing those policies and procedures. So what do we look for when we pace? What we look for when we pace is the functioning of the pacing monitor. Now on the monitor that you see here, everything's right in front of you and on the front screen. I utilize this monitor for that reason. So you're looking for your pacing functions. We're going to initiate our pacer functioning by turning it on. When you turn it on, you're going to see that pacer spike. That pacer spike is typically a downward deflection. That downward deflection is just simply how the electricity travels across the chest wall. I call that pacer spike an SA node, an SA and AV node. That's where the electricity is actually being grabbed. Your patient may feel a little bit of a grabbing or a pinching sensation at this point because you are still starting up that electrical functioning of that monitor. What we're going to do first is we're going to set our rate. As you can see, we're going to set our rate to our beats per minute. The reason why I don't have numbers here for beats per minute is quite simply because, again, everybody's policies and protocols are different. But for air of explanation, we're going to talk about 80 beats a minute. So we're going to set those beats per minute to 80. Now we're going to increase our current. Whenever we start increasing our current, it's measured in milliamps. It's not joules. We don't measure that in joules. It's a smaller amount of electricity. As you can see on the monitor, there was a change. At around 90 milliamps, we actually got functioning from the ventricles while we were pacing. This is important to note, and we'll talk about what this is and what this means whenever we see this change on the screen. So pacer spike followed by a broad QRS complex. A pacer spike followed by a broad QRS complex is what we call electrical capture. This is physically what you see with your eyes on the screen or on the monitor. Now your patient's going to be creating quite a scene inside your room while you're doing this. Why? Because it hurts. We'll talk about that pain here in a minute. But that electrical functioning and that electrical aspect is what we call electrical capture. You want a pacer spike followed by a broad QRS complex, but you want something with it. You want mechanical capture. Mechanical capture means an increase in blood pressure, an increase in heart rate, and an increase in perfusion centrally through your patient. The two of those together combined is what we call complete capture. If you don't have complete capture, what you need to do is just keep increasing your milliamps until you get both. We've had many situations here in the area where we have had electrical capture, but we have not had mechanical capture, and we've had to increase the milliamperage of the patient in order to get that. You need both in order to have complete capture, so make sure that you have both. So let's talk about our patient. We have a patient with an already low heart rate or bradycardic. They're symptomatic, which means that they have a low blood pressure associated hypertensive issue. They have a decrease in mental status because of decrease in oxygenation to the cardiac muscle and to the circulatory of the brain. Remember, we're pulling a little bit of oxygen from the brain functioning to try and get back to that cardiac functioning. It's going to leave you just enough oxygen maybe to dial 911. So what happens when we pace? Well, if I come at you and I put pacer pads on your chest, you 9 times out of 10 start thinking about television programs. You think that you're about to get defibrillated. So you would expect a little bit of an anxiety issue, a little bit of anxiousness, a little bit of an adrenaline rush. But with a sick heart, that doesn't happen. What happens is the opposite. When you start to pace, you actually get what's called the pain threshold. Now, this pain threshold starts releasing natural catecholamines and endorphins and natural pain relieving measures. So now not only is your heart fighting you solely, but now your body's starting to fight you while you're being paced. This is going to cause a couple of issues. Number one, those pain relieving measures, they're going to kind of combat that adrenaline, that also lower that pain threshold, try and get you to relax. The second thing it's going to do is start increasing your vagal tone. By increasing your vagal tone, your patient's going to be grabbing the side rails of the bed. They're going to be bearing down every beat. And in this case, it's 80 beats a minute. So 80 times a minute, he's going to be probably using a couple words that aren't appropriate at you, maybe calling you names, yelling, screaming, and definitely holding the side of the bed rails and bearing down. This bearing down does a couple of things. Of course, it lowers your blood pressure. Increasing vagal tone also lowers heart rate. You may have a syncopal episode. You may have a decrease in mental status, again, because of this increased vagal response. So we need to help combat that. I put this slide up here for humor, but in all actuality, these are probably some of the faces that you're going to encounter while you pace. Maybe at 40 milliamps and 80 beats a minute, they might say to you, yeah, I kind of feel that. Can you make it stop? And by the time you're done at 80 beats and 80 milliamps, they're going to probably want to leave. So how do we combat that? Great question. I'm going to answer it. We combat it with medications. Now, a lot of clinicians will actually give pain medications before they start pacing. I caution you on doing this. The reason why I caution you on giving pain medications before you start pacing is because I want to know whether or not that the pacing is working. I want to know that the pacing is taking effect. And I want to know that the increase in circulatory issues are being alleviated by that pacing. The best way to do that is by naturally watching that occur. If I give pain medications, that might mask that. It might cover it. So now I have the cardiac muscle fighting me. I have the whole body globally fighting me while I pace. And you're going to introduce medications that does what to my blood pressure? Lowers it. Does what to my heart rate? Lowers it. And does what to my mental status? Lowers it. So what I want you to do is just very, very, very use a lot of caution whenever giving medications. Be very non-judicious when giving medications. And watch that medication reaction. A lot of those pain medications, again, can cause hypertensive issues and do act a lot on that heart rate and that blood pressure. Typically what you'll want to do in most opinions is start to pace for a few minutes, get that circulatory system going, and then give those pain medications to combat that pain. So that finalizes pacing and pacing your patient. We're going to go now into synchronized cardioversion, or heart rates that are too fast. Again, we talked about those patients that don't meet the 150 to 160 threshold. There's patients that might be 124, 128, maybe 130. If they're symptomatic, you need to start putting into the back of your head and into your thought process, possibly needing synchronized cardioversion on those patients, especially if they're symptomatic and starting to decrease in their perfusion status. So what I want you to do when you walk into those clinical settings and you have a patient whose alarms are going off because of a high heart rate, what I want you to do is go into those clinical settings and not only do your ABCs, but also ask yourself this very, very simple question. Do I have time? Because it's really going to initiate and help you determine how you quickly and how fast you're going to treat this patient. And by asking yourself, do I have time? You're actually asking yourself a few questions. Number one, what does my patient look like? What are they presenting with? How stable or unstable are they? And what's their hemodynamic stability or their vitals, including pulse, blood pressure, EKG, what rhythm are they showing, and their SpO2. So if you look at this gentleman laying in bed, he seems pretty comfortable. He seems really relaxed. But if his heart rate's 150, 160, he might feel a little anxious. He might feel a little shaky. He might have a little bit of fluttering in his chest. This does not make your patient unstable. It does not preclude that patient from being a candidate for synchronized cardioversion. This patient is actually a stable patient and one who you can take your time on. So under that algorithm, what you're actually going to see is we're going to take time to do some things first. Less invasive to most invasive. I spoke about that many times. So less invasive to most invasive. We're going to attempt vagal maneuvers. Vagal maneuvers, of course, involve several ways and means of slowing that heart rate, done naturally 9 times out of 10 by the patient. Blowing into a syringe, bearing down, blowing into your thumb. These Valsalva maneuvers will lower the heart rate by putting pressure around the diaphragmatic area, around T4, T5 area, and decreasing that heart rate in a natural manner. If that doesn't work, we're going to go to the next manner of treatment. And that next manner of treatment is medications. The medication, probably 90% of the time that you're going to utilize, it is adenosine. Adenosine is given in 6 milligram and 12 milligram doses. We're going to talk about that later. That adenosine is given very, very rapidly and very briskly. If you are pushing it too slow, this is not a medication that's going to really give you any kind of treatment plan if you're pushing it too slow, because it's actually pulled from the vascular tissues very quickly. So you need it to get to that heart muscle fast. Large bore IVs is your choice of IV in these patients. And if adenosine doesn't work, or if your patient happens to be an AFib, you may use other medications such as cardizem. So don't preclude other medications and just say it's always adenosine. But adenosine in an Acls is probably most of the time what you're going to see maybe later on in the testing arena. If adenosine doesn't work, we're going to move on to synchronized cardioversion. Synchronized cardioversion is the actual dosage of electricity that we're going to give, and that dosage is 100 joules. Again, in pacing, we mentioned milliamps. When we're synchronized cardioversion, we're actually dealing in joules now. And we're dealing with a lot less joules in defibrillation, but we're still giving that a patient a joule setting of electricity. Now, taking a look at patient number 2, as you can see, maybe a little bit more critical. He's got a 12-lead EKG on. He's got some oxygen. It looks like he's in a bit of distress. These patients are patients where when I walk into the room and I say, do I have time? The answer unequivocally is going to be no. These patients are patients where the hair on the back of your neck stand up. If you have a patient where you walk in and you say to yourself, do I have time? The answer is no. And they have inadequate tissue perfusion. They're pale, sweaty, and diaphoretic. They're clutching their chest. They're short of breath. They're gray, pale, or ash in color. What we're going to do is actually drop the first treatment regimens as far as vagal maneuvers and medications. And we're going to go to immediate synchronized cardioversion at 100 joules. A lot of those symptoms, a lot of those signs that you're going to see that are here up on the screen, blood pressure is 70/40, chest pain, decreased level of consciousness, are all patients that you're going to see probably in written form later on in the testing process. Although 70/40 might be a normal blood pressure for your clinical area, it's not a good blood pressure. A good blood pressure is anything over 90. You might want to remember that. So anything over 90 is a really good blood pressure. Anything less than that probably isn't, even though it might be normal for your clinical area. So the AHA requires that I teach you this. As far as clinicians are concerned, they need to know this. So initial recommended doses per the American Heart Association for narrow regular complex tachycardia or your true SVTs or atrial tachs, we're going to synchronize cardiovert those folks at 50 to 100 joules. For a narrow complex irregular tachycardia, these are the patients in atrial fib, atrial flutter. We're going to dose them with a biphasic or monophasic between 120 to 200 joules, dependent on your monitor. We do have monophasic monitors still out there. They're not as prevalent anymore. Most of the monitors we're encountering today are biphasic. And for wide regular tachycardias or your V-tachs, we're going to deliver 100 joules. Now, if I walk into your emergency department and you synchronize cardiovert me at 50 joules and it doesn't work the first time, well, I'm probably 9 times out of 10 going to not allow you to give me 100 joules. So if you ever have any doubts as to what you're going to give that patient, just give them 100 joules. And if you're not sure which monitor you have, monophasic or biphasic, what you want to make sure that you do is just deliver 100 joules. Now, what we're finding for a lot of treatment regimen and a lot of studies is that for atrial fib, 200 joules is working really well for our patients. But again, the AHA has recommendations for these, and these are those recommendations. Now, monophasic or biphasic monitors, which one do you have? That seems to be the $100 question. A lot of folks aren't sure whether or not they have monophasic or biphasic monitors. Unless you're a monitor geek like myself, you're probably not going to be able to tell the difference between the two. The monitor on the left, the white monitor, is actually your biphasic monitor. The one on your right is also a biphasic monitor. It's a trick. It's actually meant to throw you off. So as you can see, some of the settings on those monitors are a little different. Again, you need to know which monitors you have. And if you're not sure, that's okay. We're just going to use 100 joules. So how do I synchronize cardiovert? Well, quite simply, you're going to look for that synchronize button or that sync button. A lot of times it's shortened because quite simply synchronized cardioversion doesn't fit on the button. You're going to press that button and activate the sync mode. You're going to see a couple of things happen. Number one, your monitor may start beeping at the rate of the patient, this being 186 at the time. You're also going to see some indications above the R waves. These indications might be in the form of dots or arrows or triangles. This is telling you that you are now in sync mode and it is finding those QRS waves, more specifically the R wave. So what you want to do is make sure that that monitor has grabbed that. If you don't see dots above the R waves and if you don't have an indication that you're in sync mode, you do not want to push that magical thumbs up button, the button that I call the shock button. You're going to charge your setting. Again, we charge to 100 joules if you're just not sure of how many joules you're going to give that patient. 100 joules is a good number. So we're going to charge it to 100 joules. And we're going to push the magical thumbs up button. I call it the magical thumbs up button because I don't like the word shock. So we're going to press the magical thumbs up button, and what's going to happen? Wait for it. It's going to take a few seconds for it to give that electricity. Now, the reason why it's going to take a few seconds for it to give that electricity is it needs to find the R wave so that it shocks at exactly the right point at the most specific time. So make sure that when you're giving that electricity, that when you press that button, that everybody stays off of that patient until that electricity's been given. Trust me, your patient's going to let you know. You'll be the second to know, your patient being the first. So make sure you allow those few seconds for it to deliver that electricity. Now, what you've noticed is after you've pressed that shock button is that it's turned itself off. It's actually gone out of sync mode. It's gone out of sync mode for a couple of reasons. Number one, hopefully you've converted into a rhythm that's good and perfusing. As you see on the screen, that rhythm is a nice perfusing rhythm. What you also want to do is make sure that it goes out of sync mode for that 0.5% of patient population that has such an irritated ventricular response, that instead of a good rhythm that you see on the screen, instead they convert into a bad rhythm. That bad rhythm doesn't need synchronized cardioverted. Most of the time that rhythm needs defibrillated. It's preparing you for defibrillation by going out of sync mode. So remember, whenever you go to synchronize cardiovert a patient a second time, should you have that need, you need to go through those steps of synchronized cardioverting again by turning on the sync button, by charging to 100, making sure the dots are above the R waves. Because if you don't, and those dots aren't present and you're not in sync mode, you're going to defibrillate your patient at 100 joules. So make sure that you do that process all over again. which leads us into defibrillation. Now, defibrillation, most of the time that patient is in cardiac arrest. Defibrillation is for dead folks. So whenever you have a ventricular dysrhythmia patient in arrest, you're going to start high quality compressions, or CPR, and you're going to get the defibrillator ready. Remember, we're going to do high quality CPR as discussed in the CPR portion of this program, and you're going to make sure that you're pushing at least 2 inches at 100 to 100 beats a minute. Well, we're going to prepare the defibrillator. As we prepare the defibrillator, we're going to look for a couple of rhythms. The first one, wide complex tachycardia, or VTach. This is dead VTach. Your patient is unconscious, there are no pulses, and your patient is not breathing. There are 3 types of VTach that's out there. There is conscious stable VTach, there's conscious unstable VTach, and there's dead VTach. Make sure that you are aware of those differences and how to treat those differences appropriately. In a conscious stable patient in VTach, we're going to give medications. In a conscious unstable patient, we're going to synchronize cardiovert them at 100 joules. That's that wide complex tachycardia we spoke about a little earlier. And for this complex or dead VTach, patients who are pulseless and apneic, we're going to go ahead and defibrillate those patients. Torsades. Torsades is a cardiac arrest rhythm. So make sure that you do have that patient on the defibrillator. Make sure that you do have electricity ready. As we give medications, medications of choices that we're including in torsades being epinephrine, amiodarone, and most importantly mag sulfate, we're going to see this upward swing of VFib turn into the VTach portion, and that patient's still going to need defibrillated. So make sure that you're ready to defibrillate those patients. And the last one, and the most common one, of course, VFib. VFib, or the most shockable rhythm that's in a cardiac arrest, we are going to, of course, look for that. We are going to give those defibrillations as fast as possible, as soon as that AED or that defibrillator is available, and we're going to determine what our electricity or our joule setting is. So, what is our joule setting for defibrillation? Quite simply, it's the highest setting possible. There's no number to remember, because all monitors and manufacturers are different. And because all monitors and manufacturers are different, all you need to remember for defibrillation is the highest setting possible. So quite simply, for pacing, it's according to your policy and protocol. With synchronized cardioversion, it's 100 if you can't remember any other number. And for defibrillation, it's just simply the highest setting possible. And remember the most important point, and the most important point I want you to walk away from this is, contrary to popular TV dramas, remember defibrillators are not meant to deliver asystole shocks. Just a little humor for you. I thank you for your time. I thank you for your patience. I thank you for listening to me during this program, and I will see you soon.
Hello, I'm Rhonda Shepard, Training Center faculty for the American Heart Association Training Center for the Allegheny Health Network. Today I'm going to demonstrate for you an adult CPR resuscitation. But before I do so, I'd like to talk about some critical concepts to consider. Let's talk about scene safety. What is scene safety, and what does it mean for us as healthcare professionals? Scene safety is more than just about the basics, the slips, trips, falls, and sticks, things we talk about regularly. We need to think on a broader perspective. Who's in the patient's room with this patient? Is there something going on in there that makes me uncomfortable to enter the room? Please, when you're assessing scene safety, make sure it's safe for you. When I approach this patient and I want to assess for their alert status, I'm going to shake and shout, "Hey, hey, are you okay?" The moment I determine they're unresponsive, that's when I call for help. If I'm alone, I may need to leave the patient to activate either emergency response system outside of hospital or calling for help inside the hospital. If I have others with me, send them to call for help while you continue with your assessment. When I assess for breathing and a pulse, I want to complete these tasks simultaneously. So I'm going to completely expose the chest. I'm going to assess for a pulse on the side that I'm on, and I'm going to watch for chest rise and fall. If I'm not sure if I'm seeing chest rise and fall, I can place my hand on the chest to feel for chest rise and fall. If I don't see or feel either, that's when I begin with CPR, starting with high quality compressions. What does a compression look like? What should we be trying to achieve? Let's talk about hand placement first. We should be placing our hands on the lower half of the breastbone, centered between the nipple line. Try to focus your energy on the heel of your hand. Interlace your fingers if you can and pull them up as far as you can. This minimizes the impact point in which we deliver compressions. We need to focus on a good depth. So how deeply should we be compressing on the chest? We want to compress at least 2 inches. If we have a feedback device, we should be striving for 2.4 inches. What is our rate of compressions we should be achieving? So we should try to be compressing at no less than 100 compressions per minute and no more than 120. That's our appropriate range, 100 to 120. Remember that recoil on the chest, or the upward motion, that chest coming back to normal resting, is also critical. So that upward motion is just as important as that downward motion. When the AED arrives, we want to use that as quickly as possible. If the person bringing the AED to you is familiar with its operation, they can apply the electrodes around your hands while you're compressing. If the AED arrives and there's no one available who knows how to use it, you may have to stop your compressions to use the AED. Remember your compression to ventilation ratio of 30 compressions to 2 breaths. For the adult victim, it doesn't matter how many rescuers you have, you remain at that ratio. When using a bag valve mask assigned by the Allegheny Health Network, make sure your PEEP setting is at 5. 1, 2, 3, 4, 7, 8, 9, 10, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. Good chest rise. Good chest rise. 1, 2, 6, 7, 8, 9, 10, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28, 29, 30. I'll show you now the AED you'll be using in your testing station. But before I do, I'd like to point out 3 critical concepts for you to keep in mind when using any AED. Important thing number 1 is to remember to turn it on. Some AEDs will turn on themselves when you open the hard case. Others require you to push a button to turn it on. Important thing number 2 is to listen to the AED and follow the prompts exactly. We want to use the AED the way that it tells us to, and not to switch the order in which we do things. Important thing number 3 is to remember all clear before you push that button to defibrillate. When you say, "I'm clear, all clear," that means you've done a visualization around the patient to make sure that no one is touching. We'll use the AED. Important thing number 1 is to turn it on. This is a 2-button system. 1 button to turn it on, 1 button to defibrillate. Listen to it.
Apply pads to patient's
Follow
bare
the
chest.
pictures on the electrodes.
Plug in pads connector next to flashing light. Apply pads. Plug in connector.
You can do this while
Analyzing
compressions
heart rhythm.
are being administered.
Do not touch the patient.
That's where you'll stop compressions to allow it to analyze.
Shock advised. Charging. Stay clear of patient.
We can take advantage of this time to administer some additional
Deliver
compressions.
shock now. Press the
I'm
arm
clear, all
now.
clear.
Shock delivered. Paused. Begin CPR.
This is where we'll resume our CPR, beginning with chest compressions.
Successful teams not only have medical expertise and mastery of resuscitation skills, they also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible. The American Heart Association has grouped the elements of team dynamics into 3 categories: roles, what to communicate, and how to communicate. Let's review those now, starting with roles. Clear roles and responsibilities should be immediately established. When all team members know their jobs and responsibilities during a resuscitation attempt, the team functions smoothly. The designated team leader should clearly define and delegate tasks according to each team member's area of competence. Every member on the team should know his or her limitations, and the team leader should be aware of them. Team members should ask for assistance and advice early, not when the situation deteriorates. Sometimes a team member or team leader may need to correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you have to correct a colleague before he or she makes a mistake, whether it's a drug, dose, or intervention. The next category is what to communicate. Knowledge sharing is a critical component of effective team performance. Team leaders should ask for good ideas for management and frequently ask for observations from team members about possible oversights. Summarizing information out loud is a good way to maintain an ongoing record of treatment and acts as a way to reevaluate the patient's status, the interventions performed, and the team's progress within the algorithm of care. This technique can also help team members respond to the patient's changing condition. The last category of team dynamics is how to communicate. Closed-loop communication is important for both the team leader and team members. When the team leader gives an order, the team member should confirm that he or she heard and understood the order. The team leader should call people by their names and, if possible, make eye contact to ensure that the team member has understood the order before assigning additional tasks. The team member should tell the team leader when he or she has completed the intervention. Team leaders and members should also use clear messages. Using concise, clear language helps prevent misunderstandings. Speaking in a tone of voice that is loud enough to understand, but also calm and confident, helps keep all team members focused on the task at hand. All team members should display mutual respect and a professional attitude to other team members, regardless of their personal expertise or training. Because emotions can run high during a resuscitation attempt, it's especially important that the team leader speaks in a friendly, controlled voice and avoids shouting or aggression. Not only is it important to know what to do during a cardiac arrest, but it's just as important to know how to work together as a team during an event. Debriefing as a team is an important component of every resuscitation attempt. Such debriefing during and after an attempt helps individual team members perform better, and it may also bring system strengths and deficiencies to light. Implementation of debriefing programs may even improve patient survival after cardiac arrest. Now we'll see the same scenario with everyone using good team dynamics. See if you can spot each key element in use.
Hi everyone. EMS just called in and said they have a 16-year-old male who arrested in their unit as they were arriving. They're unloading now and Pam is meeting them in the ambulance bay. She'll ventilate when they arrive. James and Aaron, can you two cycle through chest compressions for the first rounds? James, you're first on compressions, and Aaron, I need you to hook them up to our monitors and defib.
Yeah, I'll start on compressions.
And I'll have monitor and defib.
Okay, good, thanks. Laura, can you take IV and meds?
Yes, I'll take IV and meds.
Kayla, I need you to record.
I'll record.
Great.
Hi, we're a BLS crew with a 16-year-old male here. Witnessed cardiac arrest precisely 3 minutes ago. We started compressions, applied our AED, and gave one shock with no RUSC. We then gave a second shock at the 2-minute mark with no change that we could see. He has been easy to bag.
Okay, thank you. Let's move him over at 30. 28, 29, 30. All right, 1, 2, 3.
Okay, Mike, I'll take over compressions.
All right, thank you. Good switch. James and Aaron, you can swap out compressions every 2 minutes or sooner if you get tired. Do we have an IV?
No, I'm working on the IV now.
Laura, if you can't get the next to stick, try an IO.
Okay. I'm recording.
Okay, monitor is attached.
Hold compressions. I do not feel a pulse. He's in PEA. Continue CPR.
Okay, IV is in and flushed.
Good. Kayla, can you provide a summary of the action so far?
We've inserted an IV and attached a monitor.
As you've just seen, designating team roles and good communication allow for a rapid and orderly response in an emergency situation. Clear direction and effective communication by all team members create an environment where patients have the best chance of survival. You'll now have a chance to discuss the elements of good team dynamics that you observed in this scenario. In this video, we'll discuss how to appropriately care for and communicate with the family of a deceased patient, as well as how to care for yourself and coworkers when you experience the death of a patient. Critical care staff can confront death frequently. In our clinical specialties, we see death that is traumatic, sudden, and unexpected in all ages, from youth to the elderly. Unfortunately, emergency and critical care settings are in stark contrast to the needs of the dying and bereaved. They are fast-paced, focused on life-saving, lack privacy, can be very loud, and tend to have a poor physical layout. The dying and bereaved need time, privacy, and to be a priority. As healthcare providers in these areas, you may have to deliver news of the patient's death to the family. Let's watch a scenario of delivering this news poorly. Afterwards, discuss how this situation could have been handled better.
Dr. Schoenfeld, 305. Dr. Schoenfeld, 305.
Hey, sis.
Hey.
What's going on with Dad? Any news, or?
Okay, I went to see him on my way home, and we were having coffee, and we were talking, and then he just gets this strange look on his face, like he was confused.
Okay.
And just fell down in the kitchen.
I was worried something like this was going to happen to him. You know, he's so stubborn about taking his blood pressure meds and...
Okay, I rode with him in the ambulance, but I haven't seen him since they took him into the ER about 30 minutes ago.
Okay, has anybody given you an update, or?
No, I keep going to that desk over there, and all they tell me is that I have to wait for the doctor if I want any more information.
Are you Mr. Haven's daughter?
Yes, I'm Sarah, and this is my brother Jimmy.
Dr. Kurtz.
Can somebody please tell us what's going on with our dad? She's been asking for a half an hour.
I'm sorry, we've been very busy, as you can see, but I'm afraid I have some bad news. Your father didn't make it.
Didn't make it? I thought we got here in time for you to help him.
He had what we call a cardiac arrest, and his heart stopped.
That's not possible. He's 68 years old. This doesn't make any sense.
I'm sorry. We tried everything we could to get his heart started again, but we just couldn't. Sometimes these things happen.
But he was fine earlier today.
I understand how you feel. I'm going to get a social worker in here, one of ours, to explain some of the details. I have to get back to some of the patients that are waiting on me in the back. Stay strong.
Wait a second. I want to see my dad. Unbelievable.
Some family members may become violent upon hearing the news. It's important to keep the family members and your staff safe in such a situation, so don't go alone. Provide information in small amounts. They will only be able to handle bits and pieces at a time. Be sure to use appropriate language to convey your support. Even though we may have the best of intentions at heart, our message can come across insensitive. For example, instead of saying, "I understand how you feel," say, "I wish it had turned out differently." Rather than saying, "It was their time," say, "This must be very hard. What can I do for you?" If you're the person designated to assist the family, use common language and not medical terminology when explaining efforts to the family. If ever you are responsible for delivering bad news to a family, remember to be clear and accurate, and do it in private. You're about to play a role in one of the worst memories of a person's life. Deliver your message the right way, and you have the ability to prevent additional anger and pain from being added to an already tragic situation. It can be helpful to have more than one person deliver the news, for example, a doctor and a nurse. Ideally, family members should have the option of seeing the body. Again, this is an option, and they shouldn't feel pressured or obligated to do so. Many facilities are utilizing things such as a comfort card to help personalize the sterile environment of the patient rooms. You should speak with your healthcare system and discuss ways that are appropriate to better help families in this traumatic time. Now, let's watch 2 scenarios of better ways to explain the death of a loved one.
Beth, I got here as fast as I could. What's going on? How's Ricky?
He's in there. I couldn't watch anymore, but the social worker's been keeping me updated.
Well, what happened? What are they doing to him?
I don't know, he was outside playing and then he came in and he said he couldn't breathe. So I called for help and he seemed fine in the ambulance. And then when they were bringing him in, he was not responding and he couldn't breathe again and I don't know what's going on.
Dr. Evans, these are Ricky's parents, Mr. and Mrs. Smith.
Hi. I'm Mary Evans. I'm the doctor who's been caring for Ricky.
And I'm Martha. I've been keeping your wife updated.
How is he, doctor?
I'd like to give you all an update in private, so maybe we could find a room.
Sure. Let's go down here where we can talk.
So I understand you didn't want to be in the room when Ricky was in trouble. And I know that Martha has been giving you frequent updates. But I have some bad news. After you left, Ricky stopped breathing. And shortly after that, his heart stopped. We worked very hard on him, and we did everything we could, but we weren't able to restart his heart. I'm sorry to have to tell you this, but Ricky died a few minutes ago.
Wait, I don't understand.
Did he wake up at all? Did he ask for me?
He never did wake up. But I know he wasn't in any pain, and he didn't suffer.
Can we see him?
Of course. I'll go talk to the nurses and make those arrangements. In the meantime, Martha is going to be here for you, and she'll be able to help answer any questions that you have. I'll talk to you again after you've had a chance to see Ricky. I am so sorry.
I know you must really be shocked and hurting right now. And I'm here to listen and to answer any questions that you might have. Is there anybody I can call for you? Is there anything I can do for you while we wait?
I don't know.
I can't really think right now.
Yeah. Do you want some privacy, or would you like me to stay?
Can you please stay?
Of course, of course. I'll stay with you as long as you'd like me to.
Thank you.
Yeah.
More and more, it's becoming common practice for the family to be at the bedside to witness a resuscitation. Studies have shown that allowing families to be present can actually help the grieving process. Please stress that family presence during resuscitation is an option. They should not feel pressured or obligated to stay. They should also be able to come and go during the resuscitation as they choose. Have a designated staff member with medical knowledge remain with the family at all times while witnessing efforts. It can be extremely helpful in the grieving process if they have their questions answered about what they have seen.
This is an excellent team. They've been working hard for about an hour, so she should be out soon to talk with you.
I'm Dr. Mary Evans. I've been caring for Ricky. I know that Martha has been keeping you updated, but unfortunately I don't have any good news. You can see that we're still doing CPR, but in spite of everything we've done, we haven't been able to restart Ricky's heart. We are going to stop CPR, but I wanted to let you know first.
Wait, what? No.
No, don't stop. You can't stop.
I'm sorry, I know this is very difficult.
I understand.
Hold compressions. Stop CPR. I'm so sorry.
Can I see him?
Of course, I'll take you in.
While our focus is always on our patients, and in this case, the family of the deceased, what about us? What about the healthcare professional? We all experience both personal and professional trauma. Every person has a different threshold and range of events that can be conceptualized as traumatic. The negative outcomes from this trauma can be long-lasting. Effects can be physical, psychological, emotional, social, and spiritual. Possible examples are depression and anxiety, avoidance of resuscitation situations, hypervigilance in resuscitation situations, drug and alcohol abuse, the routinization of death, lack of compassion, and changes in worldview. We truly are the wounded healers. So, how can we take care of ourselves? In the work setting, the two main avenues are informal and formal debriefs. An informal debrief will take place within a few hours of the actual event. There's usually more involvement in this debrief because it's fresh and everyone involved is present. A formal debrief is usually 48 to 72 hours post-event. It's most helpful to involve all providers who took part in the patient's care, including pre-hospital, ED, and ICU staff. We must develop a strong positive support system at home and work. Intentionally take time away to decompress and find a way to engage in physical activity. Exercise is extremely helpful in relieving stress and providing an outlet. Finally, be aware of your stress responses and don't be afraid to reach out for help when you need to. Stroke is a leading cause of death and the #1 cause of disability among adults in the United States. We're going to demonstrate how to quickly recognize the telltale symptoms of acute ischemic stroke and model how to respond promptly with appropriate care and treatment. First, let's review the pathophysiology. A stroke occurs when blood flow to the brain is interrupted, either by a clot, called an ischemic stroke, or when a blood vessel ruptures, called a hemorrhagic stroke. 87% of all strokes in the United States are ischemic. This type of stroke occurs when plaque due to atherosclerosis collects along the walls of arteries, narrowing the arteries leading to or lying within the brain. As in the coronary arteries, disruption of the vessel wall can cause a clot to form, further narrowing or even occluding the artery. Pieces of clot can break off and travel deeper into the arteries and eventually lodge in a smaller vessel and cause a stroke there. This interruption in blood flow ceases function in the affected brain tissue, leading to a sudden onset of symptoms. Brain injury can be minimized and fatalities can be avoided when family members and healthcare providers use the stroke algorithm and follow both the stroke chain of survival and the 8 Ds of stroke care. When a stroke occurs, the stroke chain of survival suggests the following actions: rapid recognition and reaction to stroke warning signs, rapid EMS dispatch, rapid EMS system transport and pre-arrival notification to the receiving hospital, and rapid diagnosis and treatment in the hospital. The 8 Ds of stroke care act in coordination with the chain of survival. As our case study reveals, it's essential that family and healthcare providers follow these steps and work together to rapidly recognize and treat acute ischemic stroke. As you'll see, time is brain. Because many strokes occur at home, it's essential that family members recognize the signs of a stroke and promptly call for help.
It all happened so quickly. 1 minute she was fine, and then the next minute she just fell over. Ellie, honey, what's wrong? Talk to me. It's okay. I'm gonna call 911. Something's wrong. Her mouth was drooping. She couldn't speak. The whole right side of her body just went limp. Immediately, I called 911.
As you can see, the first crucial step in the stroke chain of survival is activating the emergency response system. This is also the first D in the 8 Ds of stroke care, detection of symptoms.
Rescue 21, respond. 3326 Davis Lane, possible CBA.
Rescue 21, copy.
You're responding to a 45-year-old female with notable weakness to the right side and facial droop.
The second link in the stroke chain of survival is rapid EMS dispatch. This is also the second D in the 8 Ds of stroke care.
Strokes receive a high dispatch priority, and we try to get there as quickly as possible. Part of the reason to get to them quickly is in case there's a life-threatening problem, but another part is to get them to a stroke hospital where fibrinolytic treatment can be administered and possibly reverse the damage.
They're here.
Hi, Mrs. Vega. We're going to help you out. Eddie's going to take your vitals, and I'm going to ask a few questions.
Well, the first thing I want to do is rule out any other possible causes for the patient's condition. I discovered Mrs. Vega wasn't experiencing any chest or back pain, and she wasn't having any trouble breathing. Mr. Vega also informed us that she didn't have any history of diabetes or seizures. To rule out hypoglycemia, we did a quick finger stick blood glucose analysis. It was fine. I also confirmed she's not on any blood thinners.
EMS should also test the neurologic condition of the patient with a stroke assessment, such as the Cincinnati Pre-Hospital Stroke Scale.
Mrs. Vega, can you smile for me? Okay, Mrs. Vega. Try to close your eyes. I want you to hold your hands out front. Okay. Mrs. Vega, I want you to repeat something for me. Can you say, "You can't teach an old dog new tricks"?
You can't teach dog.
The stroke test definitely showed key abnormal indicators, strong signs of a possible stroke. And Mr. Vega informed us that the symptoms had started 20 minutes before we arrived. I knew I had to make decisions quickly.
What are her vitals?
Blood pressure is 190 over 110, heart rate's 110, respirations are at 14, her pulse ox is 95.
Her blood pressure was elevated, but her oxygen saturation was normal. Mr. Vega, we think your wife is having a stroke. We'll need you to come with us to County Medical. They're specially equipped to handle the situation. The sooner we get there, the better.
Good. It happened so fast. The EMS team had her checked out in 10 minutes. And they even let me ride in the back, keep her calm and answer any questions.
The third link in the stroke chain of survival is rapid EMS transport to a hospital that is equipped to deal with acute stroke. This is also the third D of the 8 Ds of stroke care, delivery of the patient by rapid EMS transport.
Rescue 21, go ahead.
We are en route with a possible stroke patient, a 45-year-old female with weakness on right side, facial droop on right side, and difficulty speaking. While we were en route to the stroke center, I radioed ahead so that triage, the stroke team, the ED team could all be fully prepared once we arrived. Patient's blood pressure is 190 over 110. Her heart rate is 110, and her respiratory rate is 14 without difficulty breathing. Patient's blood glucose level and pulse oximetry readings are within normal limits. The patient's ECG shows sinus tachycardia without ectopy, and according to family members, the first onset of symptoms was approximately 23 minutes ago, 11 a.m., and we have an estimated time of arrival of 5 minutes.
Received, Rescue 21. We'll be ready.
Let's activate our stroke team.
There is a limited window of opportunity to evaluate the patient, determine eligibility for fibrinolytics, and start the drugs. Getting that advance notice from EMS allows me to notify the ED physician and stroke team so that they're poised to respond when that patient arrives.
The fourth D of stroke care is DOOR. DOOR stands for the effective triage of the patient, including assigning a room.
This is our suspected stroke patient?
Yes.
Okay, let's get her in 3.
Hospital personnel should assess a patient with a suspected stroke within 10 minutes after the patient's arrival in the ED. Some stroke facilities may bypass the ED and take the patient straight to the CT scan, where initial evaluation can take place. The initial evaluation should include assessment of the patient's ABCs, airway, breathing, and circulation, and an evaluation of baseline vital signs. In addition, ED personnel should administer oxygen if the patient becomes hypoxemic while en route, confirm IV patency, and draw blood samples for blood glucose, electrolyte, CBC, and coagulation studies. Even though EMS did a fingerstick blood glucose analysis, hospital personnel should review and verify blood glucose results. ED personnel should also acquire a 12-lead ECG, which may identify a recent myocardial infarction or arrhythmia as a potential cause of the stroke. This should not delay the CT scan unless there is a high suspicion of ACS. The next step in the 8 Ds of stroke care involves the collection of data.
Ideally, within the first 25 minutes of a suspected stroke patient's arrival, I get her history, perform a general physical examination, a neurologic examination, and establish a time of symptom onset. In this case, the first symptoms were about 45 minutes before. Mr. and Mrs. Vega, I'm Dr. Shapiro. I need to ask you a few questions. Can you tell me what month it is?
November.
Okay. And how old are you?
She's 45.
Okay. I understand you had some numbness and weakness on your right side earlier, is that right? After asking a few questions and performing the NIH stroke scale, there were pretty clear indicators of a stroke. We immediately transferred the patient to the CT scanner. I didn't want to delay with any other tests. Since EMS had called ahead on their way to us, we already had our neurologist standing by.
We need to get a CT scan as soon as possible, within 25 minutes of the patient's arrival in ED. Now, you have to remember the clock is ticking, so that means that you must evaluate the scan immediately. Now, our benchmark is that should happen within 45 minutes of the patient's arrival. The CT scan will help me determine if an intracranial hemorrhage is present. Now, if a hemorrhage is present, then our stroke team is going to pursue an entirely different path of treatment than fibrinolytic therapy. On the other hand, if I find a normal CT scan, as in this case, that suggests an acute ischemic stroke is causing the patient's symptoms. So my next step is to determine if fibrinolytics are appropriate for Mrs. Vega or whether I need to pursue other avenues of therapy.
That brings us to the final link in the stroke chain of survival: rapid diagnosis and treatment in a hospital equipped for acute stroke patients. This is also the 6th D in stroke care: decision regarding treatment. It begins by using the fibrinolytic checklist to see if the patient is a suitable candidate for fibrinolytics.
Well, the CT scan shows that there's no bleeding on the brain, and that makes her a good candidate for a drug that can help break up the clot in her brain. But I need to check on a few things first, if I may. With an ischemic stroke, CT scans often look normal within the first few hours of symptom onset. In this case, the CT scan looked normal and there was no evidence of bleeding. Thankfully, we were well within the window of fibrinolytic therapy, which is under 3 hours. But before I recommended that treatment, I performed another neurologic exam and I asked some questions that were part of the fibrinolytic checklist. Mrs. Vega, your right arm, can you lift it? Has the weakness improved any? Okay. And what about your right leg? Can you move it at all? Okay, all right. Can you feel that at all? How about this? Can you feel it? No? Okay. Now, could you read that first sentence for me, please? It's okay.
It's okay, honey, don't worry about it.
The neurologic exam showed no improvement. But before recommending fibrinolytic therapy, I wanted to review the patient's records and to see if there was any pre-existing conditions that might interfere with the drug treatment. These include brain hemorrhage, prior stroke, abnormal blood vessels in the brain, recent bleeding anywhere, any history of blood clotting problems, recent surgery or accidents, any history of diabetes or heart attack, or certain prescription medications. Now, I wasn't seeing any potential problems with the drug therapy. Nancy, what's her current BP?
It's 192/114.
Okay, your blood pressure's still a little bit high, so we're going to give you a drug to help bring that down, okay? Okay, let's give her 10 milligrams of labetalol and try to get her systolic blood pressure down to 185 and her diastolic down to 110. Now we'll recheck in about 3 to 5 minutes. If it's still elevated, then we need to double it or consider an IV infusion. Let's don't waste time here.
Okay, right away.
Okay, Ms. Vega.
If the patient's medical history is acceptable, if the time of onset is generally less than 3 hours, and if the patient's current condition can be managed within suitable parameters, it's time to move to the next D of stroke care: drug.
Mrs. Vega, we'd like to recommend a medication to you that may break up the blood clot that's causing the stroke. But we'd like to talk to you about the potential risks of this medication so you can make an informed decision.
What kind of risks?
There is a small possibility of having a cerebral hemorrhage that's bleeding into the brain. Now, if this occurs, Mrs. Vega's situation could get worse or may even possibly be fatal.
Well, it's only a very small risk, actually, about 5%.
That's right, but you still need to consider it. Now, the upside to this is the drug treatment may break up the blood clot in the brain, potentially restoring or improving blood flow to the affected areas, and that's a good thing.
Studies show that the drug therapy can improve the chances of recovery by 30% if administered within the first 3 hours of the symptom onset.
Now, the window can be extended for some select patients to 4.5 hours, but Mrs. Vega will easily make the 3-hour window, and that's even better.
That number works for me. Sounds like it's worth the risk. Honey?
Okay. Nancy, based on her weight, let's administer our TPA according to our protocol.
Will do.
Okay, it's going to take us about an hour to give this medication to you through your IV.
I would do blood pressure and neuro checks every 15 minutes while she's taking the therapy. I'd also monitor her neurologic status.
Good. Looks like you're in good hands. I'll check back with you after the therapy.
Patients who do not meet the time criteria for IV fibrinolytics may be candidates for other forms of acute therapy. While IV RTPA remains as the first-line therapy for acute ischemic stroke, the AHA now recommends endovascular therapy with intra-arterial RTPA, mechanical clot disruption or retrieval, or a combination of these approaches for select patients. As with fibrinolytic therapy, patients must meet inclusion criteria to be considered for this treatment. Similarly, better clinical outcomes are associated with reduced times to reperfusion, but these new treatment options offer the added benefit of expanding the treatment window up to 6 hours from the onset of symptoms. For patients who feel the risk of fibrinolytic therapy is unacceptable, healthcare providers may use aspirin and begin further stroke management. For optimal recovery, hospital personnel must carefully control the patient's blood glucose levels, temperature, and blood pressure. The final D in the 8 Ds of stroke care is disposition. This means rapidly admitting the patient to a stroke unit or critical care unit.
I instructed my staff to transfer Mrs. Vega to the stroke unit once the drug therapy started. She'll be surrounded by a team of people who specialize in stroke. Statistics show that these specialty units provide best practices and not only increase her chances of survival, but really improve her outcome as well. With a little physical therapy and time on her side, she's likely to have a full recovery.
By rapidly recognizing the signs of acute stroke and preventing delay in diagnosis and treatment, you give the patient considerably higher chances for a full recovery.
Thank you for completing your online modules for either your ACLS, BLS, or PALS course. The online video is the first part of a 2-step process to obtain your AHA credential. The second step in the process is to complete your hands-on skill testing session. Each skill testing session will begin by you completing the appropriate written exam on an individual basis. The minimum passing score for AHA written exams is 84%. You will be permitted to utilize notes you may have taken with the online didactic module you just completed. Upon successful completion of both the written exam and the skill testing session, a roster will be submitted and you will be issued an electronic AHA e-card. That e-card will come from the email address ecards@heart.org. The e-card can be saved electronically, printed, or forwarded as an email attachment. Your e-card will not physically exist until you have opened the email from ecards@heart.org and you have claimed your card. Please remember to claim your e-card. As a reminder, all AHA credentials are valid for a period of 2 years, and your new e-card will expire on the last day of the month, 2 years forward from the month you completed this course. The HA does not recognize a grace period. As a result of the COVID-19 pandemic situation, the HA has authorized an extension of existing credentials that would have expired as of March 31st, 2020 for a period of 120 days. This 120 days is unique and specific to the COVID-19 situation we find ourselves in presently. Once we find ourselves no longer in the COVID-19 timeframe, this unique online opportunity and the 120-day extension will expire. Do not expect this situation to be repeated as an option 2 years from now when your card is scheduled to expire.